Thank you, Annette. Thanks for the opportunity to speak to everyone today. And I have a few disclosures. I've served on advisory boards for Bristol Myers, Novartis, Merck, and other companies. So melanoma, as was discussed, is a problem. There are increasing numbers of people diagnosed with melanoma every year. Luckily, most of the melanomas that are being diagnosed are this is a dated slide, but most of the patients that are being diagnosed have curable disease. But unfortunately, without treatment, if you develop advanced disease, it can be quite a major issue. And when we look at survival in the days before we had effective therapies, once you developed metastatic disease, the likelihood of being alive 5 years later was quite dismal, less than 10%, less than 5%. So things really changed at the beginning of this decade when two new trial strategies for treating melanoma were developed. So one of the types of strategies is called targeted therapy. Targeted therapy comes from the understanding that tumor cells are different than regular normal cells because essentially a tumor cell is an unregulated or advanced cell that has abnormal weight. It's getting abnormal signals that cause unregulated growth. And for melanoma, what happens is that there are mutations that occur in the melanoma tumors that result in a signal through what's called the MAP kinase pathway, which results in the cells continuing to divide and grow. So a great proportion of patients with melanoma have BRAF mutations. And that is a molecule that is in between a receptor that's on the surface of the cell that then passes down signals that get to the nucleus, the brain of the tumor cell that tells it to grow. So BRAF mutations occur in about 40% of patients with metastatic melanoma, and there are recently agents that are able to very effectively target BRAF. The next most common mutation is NRAS, which is a little bit upstream. And there are other mutations that can occur in this pathway that result in unregulated growth. You don't have to have a mutation in these areas, but a very high proportion of patients do. So, and what happens essentially is that when you have these mutations, the cancer cell is always on. It's always got a signal to grow and to divide, whereas a normal cell turns on these signals and turns them off and is not growing at an abnormal rate. Now things really changed when an agent called vemurafenib, you may have heard it as Zelboraf, was discovered to be effective at targeting the BRAF gene. And essentially what happens is this mutated BRAF gene, which usually has a signal that's on, it can be drugged with vemurafenib, or the other drug that has been approved is called dabrafenib, and it turns off this signal that's always on. One of the challenges, unfortunately, with the targeted therapy is that often other signaling pathways, and what's shown on the right side here is the PI3 kinase pathway, and other mechanisms can occur that results in resistance. So this is what's called a survival curve, and this is what your cancer doctor is always looking at because it helps us to understand whether a drug is effective in resulting in improvement in patient outcomes. So a survival curve at the beginning, at time 0, 100% of patients are alive. And then with time, if a patient passes away, then the percentage of people alive decreases. With each time that someone passes away, the curve goes down. And in this study, Zelboraf, or vemurafenib, was compared to the old standard of care treatment, dacarbazine, and there was a significant difference where there was improvement in survival compared to to chemotherapy. What was disappointing, however, is that the curves come together later on at a year and a half to 2 years for single-agent BRAF inhibition. So it really was quite meaningful. We had patients who were literally on death's door, could be given this pill. The patients had a major improvement and would be able to survive. And on average, if you look at the average number of patients at 50%, you increase the survival by a few months. So this shows a survival difference of about 4 months. But remember, this is a lot of the numbers that you hear about. So if you say, if I take this pill, I'll get 4 months more. Well, you, on average, the average person would, I say, get 4 months. Some people had a little bit of extra time, and some people had more extra time. So it's always, these average numbers are hard to interpret on a per patient basis. What this is a cartoon that talks about the various mechanisms that can result in resistance, and which is a major problem, the reason why those curves come together. And what was next done in the clinical trials, which was shown in vitro, was that if you gave 2 medications, the dabrafenib or vemurafenib drug, and combined with an anti-MEK, which is a downstream signaling molecule, if you combine these 2 drugs, then you can have prevention of some of these resistance mechanisms. And what has resulted actually is that patients now, so now we're comparing not to chemotherapy, but we're comparing to single agent. In these survival curves, we're seeing that there's an improvement when you give the 2 drugs together compared to single agent. And it also looks like the curves, instead of coming together again, they actually separate out so that some people do much better for longer for long term. And there are some patients who, with targeted therapy, do particularly well, where the curves look like they're basically cured. So there are some folks that are on targeted therapy who are taking pills and have no evidence of their disease coming back. They're having to take these pills for, well, most people on targeted therapy that can tolerate the drugs will continue on treatment. As medical oncologists, none of the studies were done where you started the medicine and then after 3 years you just stopped the targeted therapy. So most patients are on as long as they can tolerate it. All of us have in our practices some patients who could not continue to tolerate, so they stopped the drug, and sometimes there's a relapse and sometimes there's not. So we have some patients that take targeted therapy and it looks as though they are cured. There's no evidence of disease coming back. People like me who are immunologists think that, of course, this is an immune response, that the immune system must have been activated in some way. But actually, we don't really know. It might just be that the melanoma tired out and that the pills were able to control it and there was low volume disease, and then patients are fine. But in the studies that have been done, the patients that do really well with targeted therapy are the patients who have very small volume disease. They have up to 3 organ systems involved, and they look great, they're doing great, and they can tolerate the medication. So when we are deciding about treatment choices, those are also the patients that do the best with immune therapy. And often what ends up happening is it is a patient choice. As Dr. Hales mentioned, we often are asking our patients to make real decisions because we can't really decide. We don't know what the best treatment for that person is based on the medical data. So we ask, well, okay, so do you want to come into the hospital every 3 weeks? Come in, then on day one be assessed, and then the next day come in for a treatment? Or do you want to be seen every month taking pills so that you can go and do other things and don't have to worry about the chemo daycare suite? So, it seems weird that we would put that sort of decision making in the hands of convenience, but when we don't have clinical trial data to tell us which is the best treatment, then life decisions can be important reasons that people make these choices. I do think that more research will need to be done to figure out which patients have other mutations that will result in them doing particularly well. So we may be able to characterize the tumors even more deeply to be able to say, oh no, you really need to go on to another type of treatment because you're at high risk of relapse soon, for instance. Now, immune therapy is something that actually is, in the media, it seems new, and certainly the new agents that have achieved approval, that's all new. But it's an idea that's been around since the turn of the previous century. In the late 1800s, there was a recognition that if you took bacteria and injected into patients, you could cause them to get very sick. But also you had some immune response, or some patients had their tumors shrink. And then over time, there's been a lot of research in understanding the immune system. And because of that research, basic research in the 70s and 80s at understanding how the immune system works, we now have a lot of tools that we're using to activate the immune system for treatment. So the basic concept of immunotherapy is that melanoma tumors express certain aspects that's called antigens that are expressed on the tumor, not expressed on other normal cells, and that those antigens can be presented to the immune system, and a T cell response, an immune cell response, can activate and recognize those antigens. So what's shown here is a tumor here that has these little star things, which are antigens. They're taken up by the quarterback of the immune system, the dendritic cell. The quarterback takes the antigen to the lymph node where it sets up an immune response. And then these little worker bees or T cell fighters then circle back to the tumor and induce an anti-cancer effect. And that probably happens in melanoma when it's very small. You actually, if you look at your path reports, there will be a comment about a T cell response, brisk or non-brisk, absent or present. Those T cells are probably recognizing the patient's tumor. When you develop metastatic disease, something happens so that the T cells are not able to do the job and get rid of the tumor. And it turns out that a major element of the melanoma that has allowed the melanoma to grow is that the melanoma is able to take advantage of how the immune system regulates itself. When you get the flu or you get a cold, you feel lousy, but you don't turn into a big giant lymph node. There are things that our immune system does to prevent an overactive immune response. And one of those is a molecule called CTLA-4, which comes up on T cells immediately when a T cell is activated. And when you engage that CTLA-4, it dampens down the immune response. Another one that comes up a little bit later is called PD-1, and that is a molecule that also, when engaged, will be downregulated. And what the new agents do is they actually prevent that what's called a checkpoint inhibitor that downregulates the T cell response. This molecule is blocked by the antibody drugs, and then that allows the T cell receptor to continue to give its strong signal, and the T cell can do its job to fight the cancer. So the big exciting results of 2012, as Annette mentioned, were that we had agents that really made a difference. As I mentioned before, when you have metastatic disease, your survival is quite dismal, and here at 3 years, patients on the control arm, only about 15% of patients were alive. But for patients who were randomized to receive a drug called Ipilimumab, there was a small but real increase in the number of patients alive. And then in expanded access protocols where large numbers of patients were treated, we saw 3-year and beyond survival rates of about 22% compared to less than 5% out at 5 years for patients with metastatic disease. So Ipilimumab, which is the first immunotherapy that was approved in melanoma, this drug, while it has a very low response rate, if you have a good response, there's a high chance of it making a big difference so that some patients basically have a home run and they're not having to deal with their metastatic disease. And they're living lives that are basically normal. The nice thing about Ipilimumab is you take 4 treatments total, and then we observe patients. So after the 4 treatments, which are very expensive, if you have this response, you can have a meaningful long-term survival. Now, the anti-PD-1 drugs are typically administered for 2 years. These drugs include, for melanoma, nivolumab and pembrolizumab are the approved drugs. Nivolumab is Opdivo, and pembrolizumab is Keytruda, thank you, yes. So anyway, if patients have a complete response, they can do quite well where the disease continues to be under control for a long period of time. So about 15% of patients on this study with pembrolizumab achieved a complete response. And what happened to these folks is that most of these patients had partial responses at the first determination about 9 weeks after beginning therapy, or 12 weeks after beginning therapy. And then a good number of these patients went on to have complete responses. In this study, it's interesting that while at 3 months, almost all of these patients had partial responses, the complete response, where radiographically we couldn't see any disease at all, this often took many, many months to actually be achieved. So patients would go on treatment and remain on treatment for a prolonged period of time before they had a complete response. What you can also see here is that after the patients achieved responses, many of them came off of treatment, sometimes for toxicity or sometimes because they had a complete response and the protocol allowed us to stop therapy. And even though these patients are no longer on treatment, they're still disease-free, doing very well. Now, the next study was to see whether you could put those 2 different types of drugs together, the anti-PD-1 and the CTLA-4 inhibiting drug. And it turns out that the combination is a bit better in terms of progression-free survival. So this is where it gets a little bit confusing. Overall survival is very easy. That's what you're either alive or you're dead. Progression-free survival means that there is no radiologic evidence of the disease growing. And there's always a little bit of a risk of progression-free survival being misinterpreted because CT scans are not perfect. But on the study, basically, there's a big difference between progression-free survival and when you had the combination compared to single agent, certainly compared to Ipilimumab or Yervoy, and even with nivolumab. One of the challenges for us as doctors is that this difference, while statistically, or it looks meaningful, it's a 8 to 9% difference, it does come with a cost, and the cost is side effects. So the combination of ipilimumab plus nivolumab in the study showed grade 3, grade 4 toxicity at 56% compared to 20% for nivolumab. In our own sort of experience, for nivolumab or pembrolizumab, side effects that are severe occur maybe in 10% of patients, and usually these are short-lived side effects that get better with time. For Ipi plus nivolumab, the side effects are severe probably in 3/4 of the patients, and they're more numerous, and there are more side effects that can occur. We can get on top of them with treatment with steroids and other treatments, but it's more serious, and they also come on a lot faster. You can have side effects just after a single dose. So in treating with immunotherapies, with these, what I like to call them, they're really non-specific activators. These immune therapies are helping your immune system to recognize the cancer, but the reason why we have side effects is that these drugs are also affecting a T cell that's going to cause colitis, or a T cell that would recognize the lung and cause inflammation of the lung called pneumonitis. So as we make clinical decisions, we're trying to balance out the benefit with the potential side effects of the toxicity. So the good and bad news is that while we have these 2 drugs that are approved, there are tons of other tools in the tool chest that have been discovered through all of that basic science I mentioned. And we have a lot of interest in trying to look at additional combinations, either to treat patients who are not able to be treated successfully by immune therapy, or so that we can deal with resistance, or to try to find safer combinations of therapies. And in terms of clinical trials happening around the world, we have tons of trials happening, not just at Princess Margaret, obviously. This is happening all over the place, US, Europe, Australia, everywhere, because there are so many different potential combinations. All of these are being investigated all at the same time. Another approach for treating patients, instead of trying this non-specific approach, is to try to enhance an immune response that's actually present within the tumor. So one of these agents is called a T-bite. Some companies, anyway, there are many different types of company names for these things. But basically, this is a synthetic molecule that has an antibody that recognizes T cells and activates them. And it's hooked up with a T cell receptor, and a T cell receptor is unique in that it's able to bind specifically to particular antigens, just like T cells are able to recognize tumor versus non-tumor. And this synthetic molecule is infused into a patient. It's able to target on one end the cancer that expresses what's called an MHC molecule that's recognized by the bite, and then it brings a T cell in and causes activation so that you can have an anti-cancer effect. What's exciting for us right now is that one of the melanomas that has been very poorly served by both targeted therapy and immune therapy, a disease called uveal melanoma or ocular melanoma, is showing some benefit in terms of a T-bite that recognizes an antigen called GP100. And in early studies, there have been a large number of patients who have had control of their disease, and previously, basically, for uveal melanoma, nothing has worked in a large number of patients. About the response rates with the current treatments are probably around 5%. So we're excited about this. The disadvantage is that patients have to have a particular HLA type, HLA-A0201, which is only present in about 40% of the population. Another strategy is to take T cell receptors and put them into immune cells such as lymphocytes, and then infuse these cells back into the patient as a treatment. And we have several of these types of studies that are ongoing at Princess Margaret. Again, patients have to have the right HLA type, and also their tumor needs to be expressing the target antigen that we're studying. We have had studies where we've treated patients and seen with these cells where we give just a single infusion and then we see shrinkage of tumor. This is a PET scan where the patient had multiple lesions present in lymph nodes and then was cleared and didn't have a relapse from their cancer. And that was done in the days before Ipilimumab. So in summary, targeted therapies are amazing. We have really good responses. Certainly the response rates, which I didn't mention before, is very high for targeted therapies, so the majority of patients can benefit. The challenge is for patients with bulky disease, aggressive disease, the disease tends to come back within a year or so after treating. But some patients can have long-term control, especially patients with low volume disease. Immune therapies are very exciting. There are many, many new drugs that are being investigated, and the response rates and potential cures in melanoma, I think, are important. And patients who previously you really didn't think they would be around for a decade are now living much, much longer and without any evidence of their disease coming back. So that's really been a game changer for melanoma. It also makes it a big challenge for patients, and I think that some of the things that you were talking about earlier, what do you do after you've been on treatment for 2 years and your doctor says you're in a complete response, but previously you didn't have patients in, we don't have 20-year-old data on what happens to those patients. So there's a lot of anxiety about having a really good result and then no longer being on treatment. And also the flip side, we still have a large number of patients who don't respond at all to treatments. So between 50 and 40% of patients still do not have meaningful benefit from these treatments. And then also for patients who have partial responses, about a quarter of those patients will have progression later. So you can be in a situation where you're thrilled, everything's great, but then the disease starts to come back and we have to come up with other solutions for those folks. So we still have a lot of work to do.